Okay, well, it's a pleasure to be here, and I hope you really weren't paying attention to all the ridiculous accolades heretofore. My email is up there. There's no need to take pictures. I'll make sure that a PDF of this is available later, so you'll have the slides. And with that, let us begin. I borrowed a few slides from my colleague, John McPartland. He's done some great work looking at pollen and figuring out the origins of cannabis. And based on those analyses, it's almost 30 million years old that cannabis is, at which time it sort of differentiated from humulus, hops, its closest relative, somewhere in the Tibetan Plateau, but it rapidly disseminated through Eurasia, and in fact was also indigenous to Europe, contrary to popular belief. Now, this would be in contrast to the endocannabinoid system, as we'll see in a minute. What this indicates that cannabis is sort of an accident of nature that tapped into the endocannabinoid system, but it wasn't put on God's green earth to make us high. Because other animals had that capability before. Okay. So if we look at the structure of CB1 phylogenetically in different species, we'll see that, as you've heard, this is present in chordates all the way down to the tunicate level. Okay, and then there are suggestions even lower than that phylogenetically. And you see some of the homology in different species. And this just indicates the same thing. If something is a vertebrate, it clearly has it. And if it has a notochord, it may have an endocannabinoid system. And then there are things where it's really questionable or they're not there at all. Same thing. But what we can ascertain from looking at this phylogenetic information is that the endocannabinoid system is actually 600 million years old. And this really highlights its adaptive nature, the homeostatic regulation of physiology that's been so basic to animals in general, with a notable exception, and that is insects. Insects don't seem to have a functional endocannabinoid system, and one wonders then how they've been supremely adapted to life on Earth. But even that's breaking down in the face of global warming and human pollution. But it may account for the fact that bugs have no sense of humor. Getting a little bit into the history, we find that treating animals with cannabinoids is really not a new thing. It's been going on for at least 1,000 years, and as usual, the written record doesn't necessarily reflect the reality out there. Clearly in India, where there's been a tradition of cannabis use for millennia, we have documentation going back to at least the 12th century. So it was used for diarrhea in livestock, to treat parasitic infestations, and then footsore disease, to increase milk flow in cows, acting as a pacifier, a tonic to bullocks, to give them increased staying power, allowing them to work. And then we see parallels to that in humans. Next one is again from India. The first modern European language documentation of Indian hemp, this would be cannabis with THC predominance, came from Garcia de Orta, who was originally a Spanish Jew, but in the service to the crown in Portugal, went to Goa in India and made the first observations in Portuguese. And he, on the first one, indicated that it lifted people above cares and anxieties and made them break into foolish laughter. That's familiar. But then the next one was interesting. Among his servants who took it, it made them so that they were impervious to the deleterious effects of work. They were very happy and also stimulated their appetite. So it's quite clear that this was a CB1 mediated kind of effect. And from Jamaica, we see the same thing. There used to be this thing, the idea that cannabis made people lazy, an amotivational effect, but that is actually contrary to the truth. Melanie Dreyer was an anthropologist who later became a nursing school dean. She worked in Jamaica and documented that the ability of cannabis to allow people to work under adverse conditions in the heat for many hours and actually increase their capacity. Similarly, among Rastafarian women who traditionally used high amounts of ganja but eschewed alcohol, they ended up with babies whose motor development was actually advanced and gained weight better than children who didn't have this exposure. We're going to be a little bit hither and yon this morning, going back to ancient times. Pliny the Elder in the 1st century talked about hemp. This would have likely been European hemp, which would have had small amounts of CBD or even CBDA, and noted that an infusion of it in water would tend to coagulate the water, but more interestingly, treated diarrhea in beasts of burden. So again, we have a veterinary application. This belief was very durable. In the 16th century in France, Rabelais noted very much the same thing, the ability of this material to kill vermin, bugs, but additionally, sovereign remedy for colicky horses and those with short breath. So what's really active here? We can speculate, but seeing that it wasn't cooked, it may well have been cannabidiolic acid. The real scientific investigation of cannabis began with this gentleman, William Brooke O'Shaughnessy, who was an Irish physician in service of the Crown who went to Calcutta circa 1936. He was an amazing man, really showing how to do modern scientific research in that he listened to the Ayurvedic physicians of India, took their advice, and then tested in various animals before treating his human patients. So he started with dogs. He was using majun, which is a confection made with hemp or hashish, and saw both the sedative and appetite stimulation effects, and also noted static ataxia, wobbliness, at higher doses, particularly in dogs, which we'll come back to. To quote, while carnivorous animals and fish, dogs, cats, swine, vultures, crows, and adjutants, that's humans, invariably exhibited intoxicating influence of the drug, the graminivorous, so grazers such as the horse, deer, monkey, goat, sheep, and cow experienced but trivial effects from any dose we administered. It's not quite right. Clearly with monkeys, they respond pretty much as humans do. There is almost exact homology in the CB1 receptor. Now, again, you may think that cannabis is new in treating animals even in modern times, but it's not, because after O'Shaughnessy, who showed the appetite stimulant effects, muscle relaxant effects, including tetanus, but also anticonvulsant effects, anti-rheumatic effects, he went back to England and Ireland briefly, and things took off from there. Use of cannabis as a medicine spread rapidly through Europe and North America, and we have a tremendous amount of documentation of how extensively it was used, and this is in all the old articles and textbooks to which I'm referring here. Lay in 1843 treated successfully equine tetanus, a disease that was invariably fatal before, and we have various other examples. Treatment of colic and urinary pain, analgesic, hypnotic, for bowel inflammation, equine cough, and canine chorea. We'll come back to that. Asthma, convulsions, again, tetanus, cystitis, etc. This extended into the 20th century. Again, all the textbooks you see from veterinary schools that are still extant today refer to this. A lot of treatment of horses, survival of 50% in tetanus, on and on, equine melancholia with pneumonia, and et cetera. Some specific examples. This one's a bit speculative. Dominic Corrigan was a character, apparently, to make money before medical school. He was a grave robber to supply the dissection labs. But beyond that, he became famous as a cardiologist. But he had case series, treatment of several cases of Sydenham's chorea, which is a post-streptococcal immune-mediated form of chorea in children over the course of 5 to 6 weeks. Now, I don't know whether this is analogous or not, but Gresswell, sometime later, noted in Korean dogs a tincture of cannabis was useful in allaying the spasms, and so this is something to consider. Muir at the University of Pennsylvania, my alma mater, did extensive work on treating horses, establishing safe doses for sedation, analgesia, and hypothermia, and also in the dog. And just some examples. These are actual medicine bottles from the late 19th century and early 20th century. This is a carminative drench. If you can read the fine print, it had ether, cannabis, capsicum, and salicylic acid. Anticolic. To me, this is really noteworthy. We have a situation of animals like horses and mules that don't have the physical capability to vomit. And so colic is a potentially fatal disorder. I also like to point out to people that these things had to have worked. We know this because these products were used for decades. In the 19th century, farmers could not afford to be sentimental about these animals. If they were going to spend the equivalent of what would be $30 today for a bottle of this stuff, it had to work, or otherwise they were going to lose a valuable animal. So again, Raleigh's colic and bloat, pictures of, again, grazing animals. But this also extended to dogs. Wirtschafter has collected a tremendous number of these bottles, noted that there were patent medicines for dogs, security cough and cold and distemper remedy would cost $28 today, containing cannabis. Quote, will relieve the worst cough, chill, or fever, influenza or mucous membrane affections of the animal's throat, nose, eyes, mouth, or air passages. Additionally, we've got hemp seed today, still used as a fish bait in some areas. Bringing things up a little bit more into modern times, a tremendous book in 1938 was this by Robert Walton, who later became the dean of the pharmacology department at the Medical University of South Carolina. So this guy was no slouch, but he wrote what was basically the best tome of literature on cannabis in the first half of the 20th century. He also did pioneering studies in various animals, but particularly in dogs, looking at dose responses. You see in the picture in the middle, normal dog, then with increasing doses of what would be THC predominant cannabis, progressive ataxia stages in C, swaying backwards, pitching backwards in D, and sort of interesting responsive scratching movements. So this is the simple way that one knows when a dog has too much THC, is this kind of truncal ataxia. And in fact, the companies that made human cannabis medicines used dogs as their bioassay. Certainly at that point, it hadn't isolated THC and there were no drug levels to be had. Now, why would this be? In fact, dogs are much more sensitive to ataxia as a side effect than humans, and we know this finally from one of the early studies of the endocannabinoid system in 1990. And if you look at G and H, you can see quite clearly they used a high-potency CB1 agonist, CP55940, to map the CB1 receptor density in the brain of various species. In the dog, in H, it's much greater than in the human in G. So I think that's pretty clear from that. And then things really got going in 1964 when Raphael Mechoulam and colleagues isolated THC in 1964. I discovered it later in 1970 under definitely different circumstances. This is going to be a review. For anybody that was asleep, I'll just hit some highlights. But, for us, it all began with a plant because the effects of cannabis were known, and I would hypothesize that without the investigations of cannabis, it probably would have taken us 3 decades or more additionally to discover the endocannabinoid system. And it was because of this lovely accident of nature that this plant in its trichomes, which you see in the middle on top, makes this stuff called THC, which is quite analogous in its effect to an endogenous cannabinoid, anandamide. Both are weak partial agonists on the CB1 receptor. And from there, the receptors were identified, the metabolic and catabolic enzymes were also identified, and the 3 together are what constitute the endocannabinoid system. And we have this concept of endocannabinoid tone that's a function of the activity of the receptors, their density, the amounts of endocannabinoids. Unfortunately, we don't have a way of measuring that non-invasively in the living person or animal at this time, but there is hope. Once again, we've got 3 kinds of cannabinoids: the phytocannabinoids, plant-based, endocannabinoids. Professor DeMarso has nicely summarized their effects as relax, eat, sleep, forget, and protect. But we could add 30 more descriptors and still be well within the capabilities. And then, of course, there's synthetic cannabinoids like the CP compound and agilemic acid. Just another diagram you've seen before. So this is really review. You've seen how active and inactive components work together in what we call an entourage effect. And these are throughout the brain. These are, CB1 is highly expressed in nociceptive areas. This is how it can be an effective analgesic, but also in limbic areas. Cannabis as an analgesic is quite different to opioids. And one way that it works, or maybe its primary benefit, is less directly on the pain than the affective components of the pain. In other words, people will say, well, I still feel the pain, but it doesn't bother me the way it did. And this is critical to patients having improvement. And no drug is a good drug unless the patient says it's helping them. Now, we should make a distinction that CB1 receptors are only in certain areas of the brainstem, and they're not in medullary centers subserving respiratory function. So there is no dose of a cannabinoid that will suppress respiration and produce apnea the way opioids do, and that's the cause of opioid-associated mortality. And then it's throughout the body, as we've seen: spinal cord, periphery, certainly in the gut. Another little pearl, it's important that you know that this thing that isn't taught in vet school or medical school, the endocannabinoid system, CB1 is the most abundant G protein coupled receptor in the brain, exceeding that of the receptors for all the neurotransmitters put together. So forget cannabis. If you accept that fact, why would we not be teaching this? It's of obvious importance to how we all function. A little bit about CB2. Professor Meshulam has elegantly described that the endocannabinoid system seems to serve a function of dealing with non-immune mediated insults. So things like trauma, where there's no necessarily immunologic reaction, but you still got to put things back together. CB2 is a great target potentially because of the fact that an agonist at it that isn't extending the CB1 will not be intoxicating. And best example is a natural product, caryophyllene, as you've heard earlier. More about CB2. This has a key effect as an antifibrotic agent. And you heard a little bit about the liver. There were concerns that CB1 agonists were pro-fibrotic. This really hasn't panned out in humans to be a problem, but clearly CB2 agonists such as caryophyllene are antifibrotic, and this knowledge can be leveraged in future drug treatments. And it's also in the skin. We've got both CB1 and CB2. Something I'm going to come back to is a little bit about cannabidiol and its effects as a TRPV4 agonist that reduces the amount of sebum in the skin, which is important in acne, and also has an antibiotic effect against Propionibacterium acnes. And then other systems. When we made this up, it was funny to me that we ended up with this spineless, heartless guy, but yet the ECS is active in cardiac physiology as well as bone physiology, and there was a fascinating paper from Kogan a few years back showing that CBD actually stimulates bone fracture healing, and we may be using this in future human and animal athletes to treat fractures if we can get the laws to allow it. And back to the plant. I am fond of saying that if you were on the proverbial desert island and could pick one plant, this is the one it should be, because you can get your food, fuel, fiber, and pharmacy from it. Just filling in a little bit about cannabidiol, it's subject to a lot of misconceptions, and I've written an article purely about that. You'll get a lot of companies that will tout the fact that, oh, we've got 2 milligrams of CBD in this. Well, CBD is a fantastic and versatile agent. However, it's not particularly potent as compared to THC, and so the numbers generally have to be higher. You will often hear it sedating, but as was alluded to earlier, this is not the case except at extreme doses. Rather, in high doses in polypharmacy, drug-drug interactions, particularly with benzodiazepines like clobazam, may make it appear this way. Additionally, a lot of hemp-derived CBD will have a lot of myrcene in it. Myrcene I like to call the couch lock factor in cannabis, because when it's combined with any amount of THC, person or animal may be immobilized. And then one of my bête noirs is the idea a few years back that CBD would turn to THC in the body. It's been known since 1940 that when you expose CBD to a strong acid, you can convert it into THC. However, this does not occur in humans. This stuff does not sit around in the stomach to allow this kind of reaction, and there's no biosynthetic equipment in our bodies to do this. Recently, there's work, it's not yet published, out of Brazil where they took hundreds of patients, giving them high-dose CBD, and found no THC in the blood of these people. So that's just wrong. A little bit more, we've heard only briefly about the acids. So these are the forms that are in the plant, and it actually is the case. There's always some decarboxylation. So this carboxylic acid group, when it's exposed to heat, light, aging, will lose the CO2, produce THC from THCA. So it is inherently unstable, but there may be ways of circumventing that. As we've heard previously, this seems to be insecticidal. More interesting, this is anti-inflammatory through tumor necrosis factor alpha. So it'd be of great interest in various autoimmune diseases such as rheumatoid arthritis and the inflammatory bowel conditions. 3 years ago, it was shown in Spain that this is also a potent PPAR gamma agonist and stronger than any of the other phytocannabinoids. And so this could be really important in weight loss, metabolic syndrome, treatment of cancer, and we'll be coming back to that. Similarly, cannabidiolic acid, this would be the main phytocannabinoid in fresh hemp. It seems to be a natural herbicide. Now, to hit on something alluded to previously, I do not believe that there's significant COX inhibition with any of the phytocannabinoids at conventional doses. The possible exception would be this one, but the doses are still rather high. And actually, the effective dose of CBDA is probably tiny because it's 100 times more potent, for example, at the serotonin 1A receptor as opposed to CBD itself. And then we've got a lot of historical data that I'm not going to go into in detail that would suggest that raw hemp was useful at treating various kinds of tumors. And this has not been investigated. So if we have any grad students out there that need a project, there's a good one. Now, I promised Connie I'd have only one slide on pain, and it's this one, and it's just to put things in context. We have a tremendous anecdotal body of evidence of the benefits of cannabis on pain, but if we look at formal published studies of inhaled cannabis, so these would be NIDA-sponsored studies from the US, in pain, it's about a total of 3 patient years, a little bit more. This slide's several years old. But with nabiximols, Sativex, just in the programs that have been done, by, say, 2015, there were over 6,000 patient years of data. Today in Canada, nabiximols or Sativex is an approved drug as an adjunct for treating opioid-resistant cancer pain. So, Connie, you're off the hook. This is a document that's gotten a fair amount of publicity. It came out in 2017 and basically indicated that there was evidence for THC-predominant cannabis in treating pain, nausea, especially with chemotherapy, and some evidence in spasticity, especially considering that Sativex is an approved drug in 30 countries for that, including Canada. However, their data cutoff ignored everything that had been done with cannabidiol and epilepsy, and we'll come back to that. So the problem with this field is it's moving so fast is by the time your paper's published, it may be obsolete. Going back to tetanus, again, we've got a situation where a disease that was not rare, we didn't have immunizations then, in the 19th century, it was uniformly fatal and really an ugly process. Before cannabis, there was no effective treatment. But there were even earlier indications of the muscle relaxant properties of cannabis dating perhaps to the 9th century. And to quote, hashish eases the muscles of the limbs and what flows. I never got to study Arabic, but to me this is suggestive of the idea that they're talking about muscle relaxation. Excuse me. It's not pharmacological. Okay. An early study of smoked cannabis, of THC at 5 and 10 milligrams shows several hours of benefit on spasticity scores. Then in 2003, there was the CAM study. This was with a non-standardized oral cannabis extract, and there was an accompanying editorial about this that basically said there was as much evidence for the benefit of oral cannabinoids and spasticity as there was for baclofen or other conventional drugs. It was about that time that the program with nabiximols was really getting going. So that's a one-to-one, basically, oromucosally administered mixture of THC and CBD along with a smattering of terpenoids. And again, a lot of fine print, but whenever anybody tells you, oh, there are no studies on that, they're almost invariably wrong. So just look at the number of studies. These are all studies of spasticity in multiple sclerosis with Sativex, and as you can see, there are a lot. This was the pivotal study we see on the left. Interesting design. There's a problem in humans with placebo effects, and it's worse with conditions in which you're studying something that has subjective endpoints. Do you feel less muscle tightness? Yes or no? We don't exactly have great ways of measuring that objectively. Additionally, cannabis, rightly or wrongly, has a reputation of being miraculous. It's not. It's really good, however, but people are expecting a miracle. So to overcome that, this design was called a randomized withdrawal. Unbeknownst to them, everybody got Sativex at the beginning. At the end of a month, the people that were significantly improved were randomized to continue on the same number of sprays a day of Sativex or the same number of sprays a day of placebo. And then there was a big divergence, and this was a pivotal study that allowed final approval in Canada and in the rest of the world outside of the US. So how does it work? Well, getting into the nitty-gritty of it, muscle tone is under tonic control of the endocannabinoid system. So CB1 agonists reduce spasticity, whereas antagonists like the synthetic SR141716A, rimonabant, the weight loss drug that's now off the market, make tone worse. CB1 receptors are densely packed in areas that subserve muscle tone, including cortex, basal ganglia, cerebellum, and also in the interneurons of the spinal cord. So clearly that's how it works. And then as evidenced in the Novotny study here, they're clinically effective. The really important distinction between cannabinoids and drugs like baclofen and tizanidine is those drugs, to be effective on spasticity, necessarily produce concomitant weakness. And the cannabinoids need not do that if the dose is right. So this is really distinct. Just a little demonstration. We see obvious equinovarus on the left. This is in a patient who's already on baclofen, 10 milligrams a day. After treatment with nabiximols, you see that the equinovarus is relieved. The caption just goes into improvements in activities of daily living, and the idea that this might reduce use of other drugs, also reduce the need for physiotherapy. After approval of nabiximols, there was an excellent review study that looked at some of the clinical trial data, but additionally 900 patients post-marketing in Spain and Germany, the only two countries where there's actual reimbursement for this drug by the government, unlike in Canada where it's never been on the provincial formularies or had that level of support. What they found was that the dose in practice was actually lower than in the clinical trials. There was a very good reduction of spasticity in the numerical rating scales. So this is the patient judging their spasticity from 6, which is moderately severe at baseline, down to 3.6, which is much milder, and that's obviously highly statistically significant. I like this one. There was one case of suicidal ideation, but that was a patient on placebo. And there were no changes in cognition, production of depression, or other mood problems, and we'll have another illustration of that. There was also a good adherence with some 2/3 of patients or better remaining on it after a year, and that's rarely the case with other drugs for spasticity. This isn't really important to animals, because except on commercials on TV, dogs don't drive, even Subarus. But there was only, in looking at driving skills, these are patients with MS before and after like a month of treatment with Sativex. The only decrement was in visual pursuit. However, that decrement there is not statistically significant. You see that everything else, cognition, reaction time, they're all improved. And in fact, something called determination was actually statistically significantly improved. So these patients were highly motivated to drive well. That's as opposed to patients on ethanol will say, sure, I can drive, and then hit a tree. So quite different. In looking at the paced serial addition test, a measure of cognition, no significant differences in before and after, but the clinical status was clearly improved. So this is from left to right, the patient global impression of change, physician, and caregiver. And so this uniform agreement with high statistical significance of improvement. And the same should prove true in animals. On the side effects side, I think everybody's familiar. Dizziness, sedation, things of this sort, clearly THC mediated. And again, in a dog, you're going to know when it's too much. You don't have to ask Fido whether he's high. And another nice rating, treating physicians rated 84% of patients as gaining worthwhile benefit from the spray. And more significant stuff, psychiatric or psychotic events, about 1 in 40, and again, 0% suicidal thoughts. Switching quickly to bladder dysfunction, early on there were quite a number of studies in lower urinary tract symptoms associated with MS, and there was improvement in just about every parameter. Unfortunately, in measuring incontinence episodes, the patients weren't able to show a statistically significant difference. These were patients that were at the end of their rope before surgery, and wasn't possible to show statistical significance. But, you know, it's been about 15 years this data's been out there and nothing's been done with it. But, again, anecdotally, a lot of patients with MS will use this for lower urinary tract symptoms. Another worry is about abuse and diversion. And this just virtually has not occurred with this product, Sativex or nabiximols. I was with GW for 11 years doing their pharmacovigilance, so I knew everything that happened of an adverse nature. And this is the one case of attempted abuse or diversion. But the perpetrator was a little dog. Anyway, he wasn't successful, and if he had been, we would have known what it looked like. Now we're going to shift into, all this material is from a paper I published a couple of years ago, and again, will be a little bit hither and yon, and I hope it holds together. So as you see, I love the history, and the idea that cannabis could be used to treat epilepsy is probably 4,000 years old. The Sumerians had cuneiform writing. They had this stuff called azala. And what they're talking about is an affliction that they called hand of ghost. And this was subsequently identified by scholars as being nocturnal epilepsy. And this azala, which had 30 different citations in the literature of that time, is unmistakably cannabis. So what evidence was there subsequently? Well, not far away in what is modern day Iraq, al-Mayusi, 900 years ago, described intranasal administration of cannabis leaf juice to treat epilepsy. Well, you know, it might have been THC, it might have been THCA, and as we've heard, that's not supposed to cross the blood-brain barrier. However, in epilepsy, we have breakdown of the blood-brain barrier. And we know, again, anecdotally, there's certain practitioners, such as my friends Bonnie Goldstein in California and Dustin Sulak in Maine, that are having great success in using THCA as an adjunct in treating intractable epilepsy, particularly in children. So there's plenty of work to be done yet. In more modern times, Wallace et al. Showed that seizure threshold is mediated by endocannabinoid mechanisms. Interestingly, in test animal, in this case the rat, they could get 100% reduction in seizures in THC, where they never achieved that with the standard diphenylhydantoin and phenobarbital. And there were additional benefits on endocannabinoid function. Most importantly, and what everybody worries about, the anticonvulsant effect was present at subsedating levels. So it wasn't just a matter of the animals were sedated and they didn't have seizures, rather an actual anticonvulsant effect without sedation. Subsequently, in Germany, there was quite a bit of work done with pure THC, treating children with spasticity and with epilepsy quite safely. And these are children that were really in a bad way, often with degenerative diseases where polypharmacy had really not produced any significant benefit for the patients or their families. There was a case of a 10-fold accidental overdose, no withdrawal effects, when the drugs were stopped suddenly. So all the kinds of worries you hear about dangerous or addictive drugs just didn't apply in this situation. Another study from Germany, same idea, use of synthetic THC in severely affected children. And you see the dose range there. There were changes, positive nature on seizures, spasms, social interaction, and even palliation and potentially fatal diseases. Again, without repeating too much, we'll just hit the highlights here. With respect to cannabidiol, as I mentioned, this was actually isolated in 1940, but Professor Meshulam nailed the structure actually in 1963. As you've heard, it barely binds to CB1 directly, but does on the allosteric site where it's a negative allosteric modulator. It is a strongly neuroprotective agent. It's stronger than vitamin C or vitamin E. Also a TRPV1 agonist. That's a possible anticonvulsant mechanism. Or it may be mediated by its ability to decrease hydrolysis of anandamide by the Phi enzyme and increase levels of endocannabinoid tone. Additionally, it works on tumor necrosis factor alpha. I mentioned again, not a COX-1 or COX-2 inhibitor. In 2005, we didn't have a mechanism of action for it as an anti-anxiety agent, and I wondered if perhaps it could be mediated by serotonin. So with colleagues at University of Montana, we were able to show that it was a low-potency agonist at that receptor, and this has been a durable finding that seems to be the mechanism of action in anxiety, but also in nausea, reduction of cognitive deficits in hepatic encephalopathy, and it may even account for some of its anticonvulsant activity because it doesn't seem to be working through voltage-gated sodium channels, which is a common mechanism of action for other anticonvulsants. Also working on adenosine receptor A2A. So when people ask how does it work, the answer is it's complicated. Some surveys, I should mention that GW was looking at CBD as an anticonvulsant throughout the first decade of the century, but in California and Colorado, people were starting to use it before it was an approved drug, and we got studies like this, survey of 150 families, and these are the worst of the worst. Dravet syndrome, Lennox-Gastaut syndrome, these are things where as it exemplified here, average of 12 anticonvulsant drugs And these are children that yet still were not controlled, and horrible situation for the families. And this is by parental report. Overall, 84% noted decrease in seizure frequency on cannabidiol, 11% complete remission, 42% with a greater than 80% reduction, and another 32% still significant reduction. There were some side effects, drowsiness and fatigue, again, probably primarily attributable to polypharmacy and drug-drug interactions. Most of these kids were already on clobazam. But there were also some side benefits. Some families reported better mood, better alertness, and cognitive gains that had not been present before. However, this is just a survey, limited duration, self-selected population. You might not tend to hear from families where it didn't work. Why should I fill out a survey? So quite understandable. Now, in humans, we've got, again, this problem with the placebo effect, and this really exemplifies it here. In Colorado, they looked at families that were native Coloradans versus those that were cannabidiol refugees that moved there to get cannabidiol, and this is an actual phenomenon in my country. But there was no real difference in response rate in various types of CBD. What was interesting was the response rate for families that moved to Colorado for treatment was 47%, where it was only 22% for those already there. And 3 times as many of the refugee families reported greater than a 50% response. There's something wrong here. We're not talking about different subspecies of humans between Coloradans and non-Coloradans. So, I mean, this really highlights that we need better studies with controls, longer durations, et cetera. Finally, things got a little more scientific in the middle of the last decade. This was an observational study by Orrin Davinsky looking at treating severe epilepsy. This is with Epidiolex, essentially 97% pure CBD. And majority of the patients over 12 weeks titrated to very high doses, 25 to 50 milligrams per day of essentially pure CBD. 25% had somnolence, 19% decreased appetite, 19% diarrhea. I'd point out that the vehicle is an oil, but only 3% discontinued due to adverse events. There was prominent sedation with clobazam, and that is a clear cytochrome P450 issue. But the solution there is to reduce the clobazam dose, not to get rid of the cannabidiol. 39% had a greater than 50% reduction in motor spells, 21% had a greater than 70% reduction, and 9% had a greater than 90% reduction, and that was true, again, even in the worst of the syndromes, Dravet and Lennox-Gastaut. And then finally into actual randomized controlled trials. This one was published in New England Journal of Medicine, 120 patients with Epidiolex, and they used a fixed dose of 20 milligrams per kilogram per day, which is still a lot of CBD and necessarily extremely expensive. There was a reduction in monthly seizure frequency from 12.4 spells to 5.9 in the treated patients versus 14.9 to 14.1 in controls. 43% of the patients on CBD had a 50% or better reduction compared to 27% of placebo, and 5% of the patients became seizure-free. None of the placebo patients did. The caregiver global impression of change improved 1 category or better. So this was convincing and was one of the several studies in Dravet syndrome and Lennox-Gastaut syndrome that led to approvals in 2018. Now, you do not yet have Epidiolex in Canada, is that correct? Right, well, hopefully soon. It does, to be honest. I worked on this drug, but it was not the preparation that I desired, I will be honest. There is nothing that CBD does where it will not work better with at least a little bit of THC. However, that wasn't the preparation that was used. The FDA did not want kids exposed to any amount of THC buying into the Kool-Aid that it's neurotoxic to the developing brain. Let me tell you something. These kids are 4+ sick to begin with. And with cognitive impairment and regression, there's nothing that THC could do that would make them worse, might contribute. The other key thing, and from a meta-analysis that was done by Pamplona et al., similar results have been seen with CBD preparations that were not pure at about 22% of the dose. In other words, it's possible that with pure CBD, you need to go 5 times higher on the dose, which is necessarily going to increase expense and the likelihood of drug-drug interactions. So I have always been a proponent of whole plant medicine for the entourage benefits of the different components, and I think that highlights the possibilities. They're further exemplified here by this preparation. This was from the breeding program of Mark Lewis. This thing is called a phytofax, and it shows the amounts of the different components. Additionally, what it smells and tastes like, and what on the third panel down on the right here, you see descriptions of the effects. And then what I really like is down at the bottom. This is showing the amount of terpenoids. So we have a high amount of beta-caryophyllene, a high amount of limonene, and we've got tiny amounts of the sedating myrcene. So this particular is what's called a type 3 plant. It's CBD predominant, but the next most common component is cannabidivarin. CBD is a good general anticonvulsant, but cannabidivarin is actually better for focal seizures, seizures of partial onset. There is a little bit of THC, which is, as we've seen, itself anticonvulsant, and there's a fair amount of linalool, the light blue here. Linalool is one of the main components of lavender essential oil and is a well-known anticonvulsant in its own right. So basically, we've got 4 separate anticonvulsants in this preparation, plus caryophyllene, which through its CB2 agonism may benefit seizures as well. I'd love to see something an extract like this employed clinically, and I would bet 6-pack of root beer, high stakes, that it would be effective. Now, anybody recognize this or care to guess the year that this quote came out? I can read it if people can't see. Because of the therapeutic failures and because of the toxicity associated with the currently used anti-epileptics, the search for relatively non-toxic drugs with different mechanisms of action is an obvious goal in epilepsy research. Both the lack of toxicity and the anticonvulsant properties of CBD combine to enhance its therapeutic potential as an anti-epileptic. Guesses? I'm sorry? We got a 1970. Any others? Well, I would have suspected you all thought it was in the last decade, but in fact, we've got a pretty close to a winner, 1979. Okay, so given this fact, in an excellent article, what happened? This agent as an anticonvulsant basically disappeared for 30 years until it was resurrected through laboratory work and subsequently surreptitious clinical work in Colorado and California. The why is because of prohibition. And we're talking about a drug that has no intoxicating properties, no reinforcing properties. It has 0 drug abuse liability, okay? So this is politics interfering with medicine, and I'm off the soapbox, at least for a few minutes. Okay, shifting gears. We've got a session on cancer later. However, cancer affects the brain, and so I put it in my bailiwick, and we'll do a little bit about it. For quite a while now, there's been good work done on using phytocannabinoids to treat cancer, and here's an example of cannabidiol treating implanted tumors in animals, and you can see the obvious difference in volume. And then we've got human data. This actually happened across the water in Vancouver. This is studies from 2 children with a pilocytic astrocytoma. These were treated surgically, but generally these always recur. These were 2 families where they decided to treat their children with inhaled cannabis, which would have been THC predominant, and the tumors disappeared. Now, I met the senior author of this a couple of years ago, and his follow-up was that these children had not had recurrence. So quite amazing for something for which we've got essentially no useful chemotherapy. There's been one study of Sativex in treating glioblastoma multiforme. So this is grade 4 astrocytoma, if you will. Now, this hasn't been published. It's remained unpublished for several years because of prolonged survival. In other words, every day that there's survival of some of the cohort, the numbers get better. And there really hasn't been any formal follow-up, but it was a phase 2 randomized controlled trial, 21 patients who had recurrent glioblastoma multiforme on high-dose temozolomide, a standard agent, plus Sativex. Now, what was particularly interesting to me is we usually say that you need very high doses of phytocannabinoids to kill tumors. Phytocannabinoids are selective in their cytotoxicity. They kill tumors, but they do not harm normal cells. But in this instance, they were using conventional doses of Sativex, up to 12 sprays a day, which would be 2.7 milligrams of THC per spray and 2.5 of CBD, doses that many patients could tolerate. And what is on the website was an 83% one-year survival versus 53% in controls. And almost nobody survives 5 years with this. And there was really no difference in the withdrawals in the treated group and the untreated group. So this is extremely promising. It appears that GBM is particularly sensitive to cannabinoids, and this is not necessarily something that's true of other tumors where higher doses are generally needed. But that's not all. Again, we come back to PPAR gamma. Just to reiterate, PPAR are nuclear receptors, so they affect gene transcription, which sounds really scary. However, agents that affect this generally have some beneficial effects. So they're involved in adipogenesis, apoptosis of cancer cells, and a lot of other functions. Stimulation of PPAR gamma may kill cancer cells without damage to normal cells, particularly astrocytes. And we're not sure, but butyric acid and capsaicin may be natural ligands of this receptor. And this is sort of redundant, but PPAR gamma has been identified in cancers from breast, stomach, colon, lung, and brain. Okay. Then, going back to something I mentioned earlier, it was shown in 2017 that THCA, tetrahydrocannabinolic acid, is a powerful PPAR agonist, more so than CBD or THC. The authors thought this was really interesting for Huntington's disease, but I thought tumors. And how might we harness this? Well, again, we've got various agents in cannabis that have benefits on tumors. On the right, you'll see a type 1 plant, so very high in THC. It's also very high in limonene in the yellow here. And so such an agent, limonene has beneficial effects on cancer as well. There was a phase 2 study of high-dose limonene in breast cancer, unfortunately unsuccessful, but it didn't have benefit of the synergy in combination with THC, so things might be different. And again, we know that there are thousands of people around the world now using cannabinoids on their own, with or without their doctor's help, to treat tumors. And we have a lot of evidence of even stage 4 patients who've been written off, sent to hospice, that have recovered and are now tumor-free. So again, it's just a matter of the studies catching up with the evidence that patients are telling us. Single slide on traumatic brain injury. I've got a lot more on this, but I hope this is something you're not seeing as much of from car accidents with pets. But both THC and CBD are neuroprotective antioxidants. That was shown in 1998, and National Institutes of Health sponsored study. There is a U.S. patent on this for 2 Schedule I agents, ostensibly with no recognized medical use that are dangerous and or addictive. We've heard about the anti-glutamatergic effect of CBD that prevents glutamate excitotoxicity. This is a huge danger in head injury because we have a situation where damaged nerves get excessive glutamate and stimulate themselves to death. That is likely preventable with THC and or CBD. We know that, truth be told, back in the 90s, I was treating my post-traumatic human patients with what would have been THC predominant cannabis in those days, tiny amounts. It would say just use enough to lift the brain fog, and we'd see tremendous improvement in headaches, nausea, insomnia, dizziness, agitation, I really think this is a treatment of the future. And the benefits in chronic conditions, such as chronic traumatic encephalopathy, that we're seeing in American football players and some hockey players, fortunately not as many, it has great promise there. Now, we're going to have a section on Alzheimer's disease. I realize that pets don't get this, but there are canine dementias that seem to be analogous, and a lot of our older animals are showing signs of dementia, so I hope that this will be pertinent. So Alzheimer's disease is a neurodegenerative disease with senile plaques of fibrillar beta amyloid from the cleavage of a precursor protein, and it produces these neurofibrillary tangles with hyperphosphorylated and nitrated tau protein. Seemingly, this is a self-perpetuating process. Once it begins, we don't know how to arrest it. Additionally, there are mitochondrial defects that, and we get increased reactive oxygen and nitrogen species, and these lead to enzymatic failure, and produce nerve cell exhaustion and eventually neuronal wastage. So you get dementia and other cognitive decline, and again, we don't know how to arrest this. So if we're going to intervene, it's got to be at a very early stage, or even pre-morbidly in those that might be genetically susceptible. We know that endocannabinoid system modulates primary pathological processes of Alzheimer's during the silent phase. So it can affect protein misfolding, neuroinflammation, excitotoxicity, and mitochondrial dysfunction. Interestingly, in Alzheimer's, we get increases in CB2 levels in the microglia, so the macrophages of the brain that work around senile plaques. These might help stimulate removal of the A-beta. Current pharmacotherapy for dementia is really wanting. We've got various antipsychotics, antidepressants, anxiolytics that are often associated with increased mortality rather than decreased. There are 4 acetylcholinesterase inhibitors to try and increase the amount of acetylcholine, the memory molecule in the brain. So 4 are approved in the USA, but none produce a strong clinical effect, and none arrest the process. There have been lots of efforts to produce NMDA antagonists, but they've either not worked or have failed to halt progression or were toxic, or all three, whereas THC and especially CBD could likely do the job. Again, this is Hampson's study from 1998. CBD is a neuroprotective antioxidant, stronger than ascorbate or tocopherol, with the US patent. Very ironic. We've also got direct evidence of both CBD and THC inhibiting plaque formation, also preventing reactive oxygen species production, so counteracting increases in intracellular calcium from A-beta. CBD inhibited tau protein hyperphosphorylation in cultures. Its mechanism of action seemed to be selectively mediated by PPAR gamma. So this is for CBD, but the same could likely apply to THCA. Again, supposedly it doesn't cross the blood-brain barrier, but that's going to be faulty in a patient with advanced Alzheimer's disease. Interestingly, we're often told you get all the brain cells you're going to have when you're born and you don't make new ones, but that's proving to be untrue. And CBD and other cannabinoids have been shown to increase neurogenesis. Again, THC has a little bit of acetylcholinesterase inhibition effects of its own, and it can prevent A-beta aggregation. On the clinical side, there have been various studies of pure THC that have shown benefits on agitation, improvement in sleep, easier nursing care in demented patients. This one was in 15 patients, and the next one was in 6. But again, these are formal studies with drugs that you can get without too much rigmarole. What about herbal cannabis? There have been a lot of things done, again, surreptitiously. My friend Jeff Hergen, works, among other things, at a nursing home in California. There's one in town where they allow cannabis and one where they don't, and all the baby boomers are trying to switch their parents from the ones that don't to the one that does. They've used a variety of things. THC, predominant, anywhere from 2.5 to 30 milligrams per dose, CBD predominant, and THCA, mainly in tinctures and confections. And they're just seeing tremendous benefits. Drug sparing of neuroleptics that, again, may be increased mortality, decreased agitation, better appetite, decreased aggression, better sleep. The nurses love it, and it's always a good thing. So how could we formulate something that might be good in treating dementia in whatever species? Well, we need to look at the target symptoms. For agitation, THC, CBD, and linalool can help. Similarly, anxiety. For psychosis, CBD has actually been shown on its own in high dose in 2 phase 2 clinical trials to have strong antipsychotic effects in schizophrenia without any of the side effects of standard drugs. For insomnia, THC and linalool. For anorexia, THC helps. Aggression, the 3 again, et cetera, et cetera. For memory, THC itself might help, but we've got another agent, terpenoid. Alpha-pinene has strong acetylcholinesterase inhibition effects. And so that combination may be really great. And for neuroprotection, combination of CBD, THC, and THCA. So another example from Mark Lewis. We've got a type 2 agent, so it's got THC and CBD, and we see a lot of alpha-pinene. This is really phenomenal. Pinene is something we don't see a lot of in most chemovars, chemical varieties, what are mistakenly called strains of cannabis. So this should be a non-sedating alternative, low amounts of THC. It's got 2% pinene alone out of a total of 4% terpenoids, which is a high concentration to begin with. So this would be a really fascinating type of agent to use in this context. Now, I'm out on a limb here. I'm going to be talking again about Propionibacterium acnes. I know dogs don't customarily get acne, but I'm dealing with a concept that I think is more translatable, which is translation of bacteria from the gut to the brain in companion animals. In humans, it's been shown that the presence of these bacteria correlate with neuroinflammation. On Alzheimer's brains, there was 5 to 10 times greater bacterial loads, especially with P. acnes. It's been cultured from Alzheimer's brains and can grow there. So this may stimulate biofilm formation, which is opposed by various cannabinoids and terpenoids, and so really could be a factor in some of the production of amyloid and other changes in dementia. And we're back to the skin. Acne seems to be well treated by CBD through 2 mechanisms. One is an antibiotic against this particular bacterium, but also as a TRPV4 agonist that reduces the sebum, which is the feedstock for the bacteria. But limonene, linalool, and pinene also suppress this bacterium. We've got the concept of the intestinal microbiota, skin inflammation, and psychiatric symptoms in what's called the gut-brain-skin axis. And we've got an illustration of that. I know this is really crude, but I worked really hard on this. So this is what I call the grand unified theory, or gut, the idea that you get translocation of enteric microbiota to the brain. This could be modified through the use of probiotics and prebiotics, possibly with the addition of select phytocannabinoids. And looking at it this way, we've got 5 agents. We've got THCA, THC, CBD, CBDA, and beta-caryophyllene and their particular effects that may be beneficial in a variety of brain diseases, including dementia. And I believe that's it.